Good morning, everyone. Welcome. So today we're diving into a really fascinating chapter, Chapter 53. Now, I don't want you to think of this as just another boring lecture, okay? This is more like a medical thriller. It's got everything, a hero, a dark secret, and some very, very important lessons for all of us. Cello, let's get started.
So let me start by asking you something. Just imagine for a moment. What is a medicine, a true wonder drug that saves countless lives, also had a dark side, a secret ability to kill? This, right here, is the paradox at the heart of the chloramphenicol story.
So, where does our story begin? Let's go back in time, to the years just after World War II. It was a period of incredible hope and scientific progress. And in this exciting new era, a new weapon against bacterial infections was discovered. This was the beginning of chloramphenicol.
And here it is, the star of our show, chloramphenicol itself. Now, take a look at its structure. See this part here? This is a nitrobenzene moiety, just a fancy name for this specific chemical group. What's so special about it? Well, it's the only one of its kind found in a naturally produced antibiotic. And scientists think this little part is the source of both its amazing power and its incredibly bitter taste. Quite a unique molecule, isn't it?
And its journey to fame was, well, it was incredibly fast. Look at this. They found it in 1947 in a simple soil bacterium, but almost immediately we figured out how to make it in a lab. And that, my friends, was a total game changer. It meant we could produce it in huge quantities, making it super cheap and easy to get. Before you knew it, it was one of the most popular antibiotics on the planet.
So why did everyone call it a winter drug? Well, it was simple, really. It ticked all the right boxes. First, you could take it as a pill, no painful injections. Second, it was cheap to make. Third, it was broad spectrum, meaning it was like a master key that could kill a huge variety of different bacteria. And on top of all that, it was stable and easy to use. For a doctor back then, what more could you ask for? Okay, so now for the fun part, the actual pharmacology. How does this thing work its magic? To understand that, we need to sneak inside the bacterial cell itself and see how chloramphenicol plays the role of a master saboteur. I want you to imagine the bacterium as a tiny factory. Inside, you have these things called ribosomes, which are like the factory's assembly line, busy building all the proteins the bacterium needs to survive and multiply. Now, chloramphenicol sneaks into this factory, goes right up to the 50S part of the assembly line, and just jams it. It stops a crucial step, preventing new protein parts from being added. And what happens when the assembly line stops? The whole factory grinds to a halt. No new proteins, no growth, nothing. The bacteria are essentially shut down. Now, this is a very important point, so pay attention. For your exams, you have to know this. Most of the time, chloramphenicol is bacteriostatic. It doesn't actually kill the bacteria. It just stops them from multiplying. This gives our own immune system time to come in and clear out the infection. But, and this is the key, if you use a high enough dose against certain bacteria, it can become bactericidal, meaning it can actually kill them directly. Okay, so far it all sounds pretty great, right? A cheap, effective drug with a very clever way of working. But this is the point in our story where things take a very dark turn. Because behind all that success, there was a hidden and sometimes absolutely deadly cost. If you remember only one bad thing about chloramphenicol, let it be this: severe bone marrow depression. Think about it. Our bone marrow is our body's factory for making blood cells. This drug, which is so good at shutting down the bacterial factory, could sometimes do the exact same thing to our own.
And the toxicity here has two very different faces. The first type is dose-related. It's predictable. You give a high dose for a while, you can expect some effect on the bone marrow. The good news? It's usually reversible. You stop the drug, and the bone marrow factory starts up again. But then there's the second type, the scary one. It's called idiosyncratic. That means it's completely unpredictable. It has nothing to do with the dose or how long you take it. It's rare, maybe 1 in 40,000 people, but it leads to aplastic anemia, a total shutdown of the bone marrow. And this is often a death sentence. It was like playing Russian roulette with a patient's life.
And as if that wasn't terrifying enough, another tragedy came to light. This time, it involved the most helpless of all patients: newborn babies. It was given a horrifyingly accurate name, gray baby syndrome. And it taught us a very painful lesson about how we treat children with medicine.
So what exactly was happening? Well, a newborn's liver is just not fully developed. It doesn't have the specific enzymes needed to process and get rid of chloramphenicol. So the drug just builds up and up to toxic levels. The baby starts vomiting, goes limp, their temperature drops, and then the most awful sign appears. Their skin turns a pale ashen gray color because they're not getting enough oxygen. From there, it leads to a total collapse of their circulatory system and death, a truly devastating side effect. So you can imagine, with side effects like these, things had to change. The era of chloramphenicol as a simple wonder drug was over. It became a kind of legend, a restricted legend, a powerful weapon kept locked away, to be used only when all else had failed.
This leads to a very logical question, one that you're probably all thinking right now. Professor, if this drug is so dangerous, why is it still on the shelf? Why are we even learning about it? And the answer, as it so often is in medicine, comes down to balancing risk versus benefit. Today, there are extremely strict, non-negotiable rules for using chloramphenicol. Rule number 1, you never use it for something simple like a sore throat. No, it's only for serious, life-threatening infections where other, safer antibiotics have failed. And as you can see, we're careful to never give repeated courses and to keep the dose and the duration as low and as short as possible. So when is the risk actually worth it? Well, in a few specific, desperate situations. In bacterial meningitis, its superpower is its ability to get into the brain, where many other drugs can't go. For series I infections, it's great because it concentrates right where you need it. And for typhoid fever, this used to be the main drug. Today, with so many drug-resistant bacteria, chloramphenicol has made a comeback as a critical last resort option when nothing else is working. So, as we come to the end of this story, what's the big takeaway? What is the main lesson I want you, as the next generation of doctors, to learn from the rise and fall of this so-called wonder drug? I think the main lesson is one of humility. This drug showed us just how powerful our medicines can be, but it also showed us how much harm they can do if we're not careful. The story of chloramphenicol literally forced the entire world to create stricter rules for testing and monitoring drugs. The lesson is simple. You must always, always respect the power of the medicines you hold in your hands. And so, I'll leave you with this final thought. It's not for an exam, but it's something you should think about for your entire career. Every single day as a doctor, you will face this question. How do I balance the good a treatment can do with the harm it might cause? The story of chloramphenicol gives no easy answers, but it perfectly captures the incredible responsibility you are all training to take on. Thank you.